Hello everyone. Today we'll be diving into an important yet often overlooked topic, congenital syphilis. Our focus will be on its natural history and key clinical features. The CDC 2021 guidelines for diagnosis and management will be dealt with in another lecture. Before we get into congenital syphilis, let's quickly review the disease course in adults. In adults, there's usually a primary stage wherein local canker formation happens along with a localized lymphadenopathy, followed by a disseminated bloodstream infection called secondary syphilis, wherein systemic manifestations happen instead of local manifestations. After which, the disease enters a long period of latency before manifesting itself again with chronic inflammatory changes of tertiary syphilis. In contrast, a fetus acquires the disease vertically from mother and therefore surpassing the primary stage completely. The fetus directly develops a disseminated secondary disease to begin with. Congenital syphilis, therefore, it has two stages, early and late. Early manifests within 2 years of life and late manifests beyond the 2 years of life. During pregnancy, in early trimesters, placenta sort of protects the fetus from getting infected, but this barrier function, it weakens as the gestation advances. That means the risk of fetal infection, it increases as the pregnancy progresses. Also, a mother with an early stage of syphilis, primary or secondary or even an early latent stage, is far more likely to transmit the disease than one who is in a late latent or tertiary stage of disease. This is where Kasowitz's law, also known as Diday's law, comes into play. It describes an observation that the risk of vertical transmission of syphilis from an infected untreated mother to her fetus decreases with subsequent pregnancies, though the risk is never completely eliminated. If you look at this pedigree, both the parents had syphilis. The first two pregnancies resulted in early neonatal deaths at day 1 and day 10. The next two children, they survived but had clear manifestations of congenital syphilis aged 11 and 9. The later children, they were born without any clinical disease. This pattern, it highlights how maternal immune response and disease progression influences the fetal outcomes over successive pregnancies. And how does the infection manifest? It can have varied manifestations ranging from a severe intrauterine infection with non-immune hydrops or an intrauterine death or miscarriage to a subclinical infection wherein only there is laboratory or radiological evidence of the disease and just no clinical features at all. Most kids are asymptomatic to begin with, but they do manifest the disease in some form at least as they grow older, manifesting either early or late features or one progressing into the other. Here is an antenatal ultrasound of a fetus with congenital syphilis demonstrating pleural effusion, ventriculomegaly, ascites, and an elevated MCA Dopplers, which was around 1.45 multiples of mean, signifying a moderate fetal anemia. This is a classic picture of fetal hydrops wherein at least two cavities have evidence of fluid accumulation. The good news, this is one of the few congenital infections wherein in utero treatment has been shown to be effective. This mother, she received 3 doses of penicillin and on follow-up, all hydrops related features resolved, indicating a successful treatment of the fetal infection. This highlights the importance of early screening and maternal treatment, which can basically completely prevent the neonatal complications. When congenital syphilis manifests neonatally, the most consistent and early finding is radiographic bone changes. If we look at a bone, we have metaphysis, physis, epiphysis, diaphysis, and periosteum. The corresponding features that develop with infection are metaphyseal fraying, osteochondritis, dislocation of epiphysis, osteomyelitis, and periosteitis. All of these are features of early congenital syphilis. There can be organomegalies, disseminated lymphadenopathies, especially including the epitrochlear nodes, jaundice, serum transaminitis, anemia, respiratory distress, which can manifest as pneumonia alba, especially in developing countries like ours. The neonate can be SGA, so on and so forth. We'll learn about a few named findings. A unique pathological feature in congenital syphilis is chronic necrotizing pneumocystis. Grossly, the umbilical cord appears chalky white with inflamed blue-red spiral strips resembling a barber's pole. This is a classic sign but is often overlooked. Coming to radiological signs, if you notice in this radiograph, the metaphyseal ends, they are not smooth. They appear frayed or sawtoothed or ragged. Along with this, if you notice carefully, in the metaphyseal region, there are linear stripes of radiolucency alternating with radio-opacity, giving it a celery stalking appearance. In this radiograph, we can notice a florid periosteal reaction or periosteitis along with a destructive metaphysitis. This destructive metaphysitis, when it occurs bilaterally in the proximal medial tibia, it is also known as Wimberger's sign. This radiograph again demonstrates a florid periosteal reaction. Then we have pneumonia alba, a relatively rare finding. It is more commonly seen in developing countries, however. We had a 30-weeker outborn kid with no apparent cause leading to prematurity. Everything else seemed normal, including a maternal first trimester serology for syphilis. Initial management as typical preterm RDS showed no improvement, however. That's when one of our APs, he noticed copper penny lesion on the kid's palms and asked us to repeat the mother serology. And it came positive for syphilis this time. The kid's titers were done and penicillin was started, to which we saw a dramatic response. So basically, it wasn't just a typical RDS. We had an overlapping picture of pneumonia alba with prematurity-related respiratory distress. You should know that syphilis, it is a great mimicker. It can mimic RDS, sepsis, cholestasis, almost anything and everything. Over here, you can notice dry, desquamating, usually weeping lesions of palms and soles, also known as pemphigus syphilitis. And after peeling, it forms copper-colored crusts, also known as copper penny lesions. They can be mucocutaneous manifestations at the corners of mouth, where in radial cracks, they traverse the vermilion zone. And in chronic setting, in late congenital syphilis, these radial scars, they manifest as ragades. Other features of late congenital syphilis include certain dental stigmata, like mulberry molars, wherein instead of 4 cusps, the first lower molars have multiple cusps. When permanent central incisors are affected, they usually become small, widely spaced, and notched. These are called Hutchinson teeth. A chronic osteochondritis of otic capsule leads to cochlear deafness. A similar inflammatory process in cornea causes interstitial keratitis, and these two, along with Hutchinson teeth, form a part of what's called Hutchinson triad. Then we have saber shins, Claton joints, saddle nose, perforated palate, and something called as Hygomenakis sign, wherein there is an asymmetric or unilateral prominence of sternoclavicular joints. All of these reflect chronic inflammatory changes which happen because of the infection. And these are just a few named findings. Congenital syphilis has countless manifestations. That's all about this lecture. We've covered the natural history, clinical features, and classic findings of congenital syphilis. I hope this helps you build a strong foundation in understanding the disease. In our next session, we'll dive into the CDC 2021 guidelines for managing the congenital syphilis. So stay tuned for that. Until then, make sure to revise what we discussed today. If you found this helpful, don't forget to share it with your friends. And if you have any doubts or topic requests, drop them in the comments section below. I would love to hear from you.